Hello, everyone. My name is Aistra Manoskaite, and I'm truly delighted to welcome you to already the 17th You Care for You webinar. Many of you know that our mission here is simple yet very, very powerful. We aim to bring the latest insights into the world of Urticaria straight to your screen. We try to explain everything clearly, simply, and delivered by the most brilliant minds in the field that are shaping the future of Urticaria. And today we are joined by exceptional panel of the experts. Dr. Carolina Vera Ayala from Charité Berlin, Professor Jonathan Bernstein from Cincinnati in the USA, and Dr. Vildana Mujkic from Sarajevo, Bosnia and Herzegovina. With expertise like this, you can be sure that today's session will be nothing but outstanding one. And the UCARE team has invested enormous effort into building the program where you, as a patient, are always at the front center. Today, more than 200 people are joining from more than 62 countries all around the world, and that truly is fascinating. Why? Because we're focusing on one of the most, if not yet the most, crucial pillars of the care of urticaria. And that would be the guidelines. Today, we are having an absolutely extraordinary opportunity to take a glimpse into the guidelines before it's even published. And as you know, the guidelines, they represent international consensus-driven recommendations built on the newest research and deep understanding of the pathophysiology of urticaria. They outline how the disease should be diagnosed, treated, and managed in the most efficient way, including those important tiny little nuances that matter in special and complex cases. And today, we're diving deep into this field. Today, we will discuss how are these new guidelines formed, what is the most relevant, and Carolina will walk us through the newest recommendation. Later on, Janet will explore how they can be implemented in the practice and what changes for you as a patient may be expected in your daily life. Vildana will ensure patient voices are heard, and we will get a chance to discuss a little bit more how the guidelines are fulfilling the current needs of our patients. So your questions are standing at the forefront today and matter the most. We're here to help you understand the new guidelines and to know what to ask your physician at your next appointment. Please be sure to use the Q&A box, and I will try my best to have all your questions answered by our experts joining in today. As always, your feedback is invaluable. It helps us to make these webinars more engaging, more interactive, more attractive, more useful for you, for our patients. So please take a moment after the webinar, share your thoughts by scanning this QR code. We will be very happy to receive your feedback. And a tiny little reminder, under the UCARE umbrella, there is much more to explore than only the UCARE for You webinars. Stay informed by subscribing to the UCARE newsletter or stay connected with us through the social media channels to never miss an important update or opportunities for you. So I thank you all for taking time to take care of your urticaria today and taking a little bit more interest in how the urticaria works and what new guidelines are offering us today. So without further ado, I would like to begin our beautiful webinar. And Carolina, welcome. The stage is all yours. Guide us through these new guidelines. We are very much excited to hear from you.
Thank you, Aistra. I will just share my screen presentation. Are you able to see it?
Yes, everything looks absolutely great.
Perfect. So, hello everybody. I will be presenting the new guidelines and the treatment options that are included. So, oops. I have no conflict of interest regarding this presentation. And the international guideline was as an initiative from GALAN, so Global Allergy and Asthma Excellence Networks, which is based with Urticaria and Angioedema Cares Centers of Reference and Excellence, which are the UCARES and the ACARES. For this seventh consensus that took place on the 7th of December last year in Berlin, 210 experts took participation from 106 different national and international societies from over 59 countries. The experts were selected by the societies, and then they were divided in two groups. Either you could vote on definition, classification, and diagnostics, or also the therapy treatments, or you could vote for everything. So based on that, the guideline has 4 different parts. So there is a definition of what is urticaria, classification, what are the different types of urticaria, how do we do the diagnostic, and then how do we treat it. And I will also talk a little bit about all these 4 points. So as definition, urticaria is a condition characterized by the development of wheals, angioedema, or both, which can appear all over the body. These wheals are usually really, really itchy, and they last from a couple of hours until less than 24 hours. The angioedema, or the swellings, are swellings of the mucosa or the tissue, which can lead to a swelling that is more painful than itchy, and it can take until 72 hours. Based on the classification, we have 2 main things. Based on duration, we can call it an acute urticaria or chronic urticaria. Here we see that acute urticaria takes place less than 6 weeks, and chronic urticaria takes longer than 6 weeks with the symptoms. Acute urticaria is a really common disease, and at least 7 from 10 people will have it at some point in their life, and chronic urticaria is more seldom. It's not that common. It will be from these 10, 1 or 2 from these 10 people, which will have it longer than 6 weeks. Then we can also classify the disease based on the subtypes, and here we have for the chronic urticaria, the chronic spontaneous urticaria, and the chronic inducible urticaria. As the name says, when it's chronic spontaneous urticaria, the symptoms are longer than 6 weeks, but we don't know to what do you react or what is the cause. And in the chronic inducible urticaria, we do know what triggers the symptoms. This is either cats, or cold, or pressure, or the sun, sport, or even water. So how do we diagnostic, or what do we use? So for acute urticaria, there are not diagnostic tests. We just evaluate how long it takes. This is usually like you get a cold, and after the cold, then you will have these wheals or the swellings for a few days, and then they're gone. Or you go through a lot of stress, you have a really important exam, and through the stress, it will come out. And then after the test, the symptoms resolve. But if you have a chronic urticaria, we have different tests what we can do to in order to diagnose the disease, and also exclude other differential diagnostics. So what the guideline says is that this 4 parts of differential blood count, CRP, IgG, anti-TPO, and total IgE are recommended to be tested. And in the case that these are normal or you cannot find what it is, you can also look for infections types, like for Helicobacter pylori, or a serum test, thyroid disorders, or even for other types of angioedema that will leave us and give us a clue in which way your urticaria is going. If you have ACINDU, so in chronic inducible urticaria, there are different provocation tests that we are able to do. So for symptomatic dermographismus, we will scratch the skin with this Frick test, which can give us 4 different time points or pressure points. And based on this, we can say how stark is the disease. Then we have the intent test for cold and heat urticaria. As you can see here in the image, it goes from 4 degrees to 44 degrees, and then you will have a wheel that tells you what your temperature threshold is. We have also for delay pressure urticaria. This is a weighted tube, so we put it on the arm or on the skin. We wait 10 to 15 minutes, and then 10 to 15 minutes after, we read also if a wheel came, and then in this specific point. We have also specific lamps to test solar urticaria for UVA and UVB, and we can also use a vortex to measure with a vibratory effect. If when it vibrates on the area, then you get also a reaction. And for cholinergic urticaria, so when you have induced through a sport, there is also a provocation test that you can ride a bike under Hertz frequency and monitoring for half an hour, and then we see how you react and if you get through the movement of the sport the wheels and the symptoms of the urticaria. So the important part of the diagnostic is confirming and excluding other differential diagnostics. This didn't change. This was basically the same as what we have in the last guideline. So we have here, you either have wheals, angioedema, or both. And then if you only have wheals, but the wheals have also they don't come alone. You have also a fever, you have joint pain, bone pain, or other symptoms, then we have to see if that goes into an autoinflammatory disease or rare disease, or if you don't have any symptoms, but it takes more than 24 hours, then we have to also check that you are not going to a vasculitis. So if it's an autoinflammatory disease, then we will do also more tests, like included on the blood exams, and maybe then we find a acquired hereditary autoinflammatory disease, which are mainly moved by interleukin-1. If the wheals take longer than 24 hours, we have to do a biopsy of the wheals, and in order to see if it's a urticaria vasculitis, or if they don't, then we go for inducible symptoms, or then we do a provocation test, and then we see, okay, it's either a spontaneous urticaria or inducible urticaria. And then for the angioedema part, did the patient take before this ACE inhibitor treatment, which is a really common use blood pressure treatment? If it is, then we stop with the medication and we reassess. Sometimes, even though after stopping, then you will continue having the swellings. But if the patient didn't have this medication, then we will go more into hereditary angioedema, acquired angioedema with C1 inhibitor, which will also be measured and tested. And then we can see, okay, it goes basically inducible terms. Is it going on the urticaria side, or is it more bradykinin based, where we have different mutations? And then we talk about hereditary angioedema or acquired angioedema due to deficiency of C1 inhibitor. So what do we use in order to control activity, impact, and control? We use for this prompts, which are questionnaires that we can use, or the patient can fill up regularly. So we have the urticaria control test or the angioedema control test, which are a short questionnaire which has 4 or 5 questions, so 4 and 5. And it will give us a basic understanding how was the last week, how was the last month, or how was the last 3 months. Then we have the Urticaria activity score or the angioedema activity score, which is like a small diary that the patient fills up every day. And the first question by this questionnaire is, do you have symptoms today? If the answer is no, that will be everything for today. If the answer is yes, then you have to fill up a few more questions on the day. How many wheals did you have, or did you have angioedema? How many? So if you had it, where was it? How long did it take? Did you take medication for it, or you didn't take any medication? And then the last thing that we can do is the questionnaire for quality of life. We have the CU and the IEQUAL, which are a little bit longer. There's about 30 questions in each questionnaire, and will help us understand where is your quality of life more impacted or affected. So based on this, we can see if the medication that we're given at some point at this time point is working or not, or if we have to do something else and either change the medication or update the dose or change to something another therapy. So with that, we come then to management. So we have this act and adjust and assess. So like I just said, we will give you a medication, we'll modify the treatment and treat the comorbidities. We also have non-pharmacological interventions. A few years ago, a diet was recommended. Right now by this new guideline, diets are only recommended if you have a specific problem and just for a short period of time in order to do the diagnostic. So when I'm talking, it's about 2 to 3 weeks, no longer than that. If not, you're able to eat everything. We are focused on educating the patients and the family of the patients and how to get the best control of the symptoms. And our seal is that you have no symptoms at all and that we can control the disease. So we see our patients about every 3 months, and then we assess, did it work? Do we have to do more diagnostic procedures? Did the comorbidities, if you had a thyroid disease, did we get that under control, and that also got the urticaria under control? Did the severity improve, or did they stay the same? The patients reacted and tolerated well the medication and doesn't have any side effects, or if there are side effects, then how can we change the procedure so that that we get to this urticaria UCT control 16 points when you don't have any symptoms anymore. So with that, we basically start with an UCT less than 12, where we have a lot of wheels, a lot of disease control, disease activity, and you're basically uncontrolled. So here we start with the medication, and we then follow up after 3 months, and we would like to see that after 3 months you get from the red at least to the yellow, and then from the yellow 3 months later to the green. That's a little bit how we want it to work. So then we have the management part, where we start treating the urticaria with second generation antihistamines, and this can be once a day. But if that doesn't work, you can update up dose to fourfold, so you can have 4 tablets a day. This first part should be also considered from your normal physician can give it to you, and if that doesn't work, then consider the referral to the specialist. Here you will see that a few colors will come out. So dark green, like it's here, it's a strong recommendation with more than 95 agreement of all the experts. Then if that doesn't work, so you tried it at least 4 weeks and you still, after taking 4 times antihistamine, you still have symptoms, then what do we do? So depending on comorbidities, what it was, the last guideline was directly going to omalizumab, which is already approved. Now we have in this same level dupilumab and remibrutinib. Both of these medications are already approved by the FDA, so they're available already in USA. And there's also dupilumab in countries like Brazil and Japan. In Europe, we are waiting for the approval of the EMA, which should be coming in every day, so any day now. And remibrutinib is also approved by the FDA in the US, and in Europe it's expected by the end of the year that we will also have it available here. So you can see here the dose of omalizumab will be 300 milligrams every 4 weeks. It's a subcutaneous injection, and the patient can give it themselves. And then we have dupilumab. It's also depending on the body weight. You will start with a loading dose of 600 or 400, and then either 300 every 2 weeks or 200 every 2 to 4 weeks, depending on your body weight. And then for remibrutinib, we have, it's still on label. The expected dose is 25 milligrams twice a day, so one tablet in the morning, one tablet in the evening. And this step should be already done or performed under the specialist or the expert supervision. If that doesn't work, then what do we do? Then you can either combine it with cyclosporine or stop the medication and then go to cyclosporine A. And if that doesn't work or it's not available, then you can add still here again the second generation antihistamines and one of the following recommendations that I will give you next. As you can see, this box here in yellow are for other therapies as a recommendation that cannot be made because it's not scientifically evidence-based. These are recommendations of colleagues that said, hey, we didn't have these medications approved in our country and we had to find an alternative solution which worked for us, but there are not really studies made for these medications. And these medications are, so we have 4 different alternate or groups, so widely used. Then we have the antidepressants like doxepin, diet, H2 antihistamine like ranitidine or famotidine, and other immunosuppressives like methotrexate, leukotriene receptor antagonists like montelukast, and sulfones like dapsone. Then, not infrequently used, we have anabolic steroids like danazol or anticoagulants like warfarin, antifibrinolytics, tranexamic acid, immunomodulators like plasmapheresis or other groups like you can see here, phototherapy and psychotherapy. And then rarely used and very rarely used, where we have other anticoagulants like heparin, other anti-immunosuppressive, and then other types of medications, as you can see here, which has been tested by some of the experts and worked. Maybe there is only published as a case reports, but they are not really evidence-based studies for these medications. That's why the guideline cannot give a strong recommendation. Then also in the guideline, there are like an area for special populations, which are our children's and pregnant women and lactation. They recommend or they suggest that the algorithms should be the same. So diagnostic for kids should be the same. You can do the blood test, you can do the provocation test. This will depend on, can be adjusted on the age of the kid. Maybe like the scratch test or the temperature test are easy to done also to be done in small children, but the bite test can be done on elderly children and not so young children. And the same thing happens with the medication. You have to also adjust the dose of the medication depending on the weight of the kid. And for pregnant women and lactation, so the treatment algorithms also goes, you have to assess the risk benefits of the medications. Approved right now are just the antihistamines, but we had also a project where we had patients that were under omalizumab and were pregnant and decided to stay under the medication and how that goes. And we didn't see any affection, so you can also talk to your physician on what the recommendations here are. And it's a strict recommendation also to help you as a pregnant woman or during lactation to still get your symptoms under control. And with that, the guideline concluded that we still don't know a lot of stuff and that we need further research. And it highlighted different areas that we will be working on and researching in the next 4 years based on pathophysiology, epidemiology, and new treatment approaches to help our patients. And with that, I would like to say thank you for your attention.
Thank you for your great work summarizing and presenting us the newest guidelines. This is always a huge, huge topic and very hot topic. And I do believe there were a lot of discussion happening behind the scenes. So we will definitely get also into that. But before that, I would gladly ask Jonathan to take the stage. Welcome to our beautiful webinar, and we would gladly have your further insights on the practical applicability of the newest guidelines that are coming up.
All right. So first of all, I think it's important to recognize from the first discussion that the patient's journey with CSU is associated with significant disease burden. You can see that from the time that patients start manifesting symptoms to the time they're diagnosed and achieve proper management can be several years. So how can we improve this process? How can we diagnose earlier? How can we implement the guidelines that were just discussed and give patients relief much sooner? Well, certainly they won't get relief before 6 weeks, right? Because chronic spontaneous urticaria, you have to have at least 6 weeks. But for instance, within the first 2 to 3 months, one should be able to recognize that there's a problem here, and we can shorten this journey. This is a survey from Urticaria Voices, which looks at the patient's perspective regarding how urticaria affects them, and you can see that the patients are in blue is all patients with urticaria. In the light blue, it's patients who are adequately controlled and patients who are inadequately controlled. And quite frankly, irrespective of whether they're controlled or not, there's significant burden associated with this disease. Taking just not only having the hives, but the impact of taking therapies and such, and the chronicity of this condition. So it's not a trivial disease by any means. And again, looking at the physician's perspective, you can see that this is again from 7 countries. You can see that there is a significant consensus, and that patients have it does affect a lot of their quality of life issues and activities of daily living and so forth. So I think that it's a universal problem. Now, when we think about implementing guidelines, do we need to differentiate patients with different types of hives? Does one size fit all? And so this is where they bring in the concept of phenotypes and endotypes, and basically this is just an example that there are many different types of buckets you can put patients in, so to speak. So, for instance, patients who are responsive to antihistamines, H1 antihistamines would be in one type of phenotype. And those are obviously the ideal patient. They're easy to treat, low cost, and can be well controlled. But there is that other population that's antihistamine unresponsive. We've had other characteristics of calling it type 1 autoallergy, where people make Ig antibodies against self, and those patients also tend to be responsive to medications, but may require more advanced therapies. And then the type 2B autoimmunity, where the chronic autoimmune urticaria, these patients tend to be less responsive to some of the medications that we have available, including omalizumab. They do not respond as well to omalizumab in their management. And then we have, of course, chronic urticaria with CIndU or CIndU alone, and some of these conditions respond to some of the therapies we have, but some of them do not respond as well. So there's certainly a need for additional treatments that target not just IgE pathways, but other non-IgE pathways to address some of these conditions, some of which may be neurogenic in mechanisms, activated through neurogenic pathways. And I think it's important to recognize the strong interaction between mast cells and neuronal cells, and how they are constantly communicating, and how they can be activated through these other non-IgE pathways. So this is the guideline that was just reviewed, the international guidelines, and basically I'm not going to belabor this, but you can see it's fairly simple. There's only really 3 choices, and then there's a bunch of other off-label, poorly scientific options. And so we really have a need for more therapies. I should say that we in the United States, in the American Academy of Allergy and College, are through the Joint Task Force, are developing a great guideline that hopefully will be introduced in the beginning of the first quarter of 2026. And these are some of the systematic reviews and meta-analyses that we did with some of the treatments. This is the antihistamine treatment, and you can see the contrast between the different types of antihistamines and their ability to control itch and urticaria and wheals, and their effects on sleep and quality of life, and then and sedation. And so I think it helps when we have this type of granular information in making selections and choosing the right treatments. And and this is what's been used to implement, to help develop some of the recommendations for our guidelines. And here again, looking at leukotriene receptors, and looking at the number of randomized trials, and the number of participants, and the age ranges, and the urticaria types, and the interventions and the comparators. And also this has helped us looking at these are the types of studies that we use to help develop our great guidelines. And similarly, we have done a systematic review and meta-analysis for topical steroids, but also for systemic steroids. And I think that this information is forthcoming. But needless to say, we have gaps in treatment, because this was an older study that we did right around the time omalizumab was introduced, which showed that up to 40% of patients with chronic urticaria are not well controlled on just antihistamines or combinations of H1, H2s, or other, first generation type antihistamines, and so forth, different combinations, and that a significant percentage of patients still required oral corticosteroids or cyclosporin. With the age of omalizumab, we've made great progress, but still only up to about 40 to 45% of patients have a complete response. So there's still a lot of patients who are partial responders or non-responders, and again, this is what we have to address. Now, with this drug we've developed, we've learned about several potential biomarkers that might be useful in helping to predict the response to treatment, which could be helpful in how we implement treatment recommendations, at least for omalizumab. However, these same biomarkers have not proven to be very useful in some of the newer novel therapies that have been introduced, at least thus far, and we'll need more real-world evidence to understand who are the responders and non-responders to medications like dupilumab and remibrutinib, which are the two newer therapies that have been approved, but it won't necessarily be the same biomarkers that have been observed for omalizumab. As I mentioned, dupilumab has recently been approved in the United States, and based on two double-blind placebo-controlled trials, Cupid A and Cupid C. Here I'm showing Cupid B, which really did not meet statistical significance. This group included patients not responsive to omalizumab, and so the question is, what will be the impact of this therapy in patients who are omalizumab unresponsive? And we don't know yet, but the Cupid C study definitely showed that there was a significant response and compared to a placebo, similar to Cupid A in terms of reducing itch and hives and controlling urticaria overall. Similarly, the remibrutinib was recently approved, which will add to the armamentarium of treatment. This is the first small molecule that we have now, and it showed that there was significant improvement in Remix 1, Remix 2 studies, showing significant benefit compared to placebo in controlling itch and hives and so forth. And so the important thing that it is a first of its kind in terms of BTK inhibitors. It has a rapid onset of action. And what's interesting, it seems to be effective regardless of prior exposure to anti-IG biologics. And also it works independently of baseline total IgE levels and has sustained efficacy. So, and improves quality of life. So this is very useful when we think about how we're going to implement treatment options. And again, this summarizes these small molecules. Again, in our grade guidelines, another systematic review meta-analysis that was published in JACI this year, looking at the comparisons. And then the question is, what will be the recommendations, how we implement these drugs? Should they be equally considered as one safer than the other and based on evidence? And so those recommendations will be forthcoming. But not needless to say, there's a number of other these systematic reviews for your reference that you should review, because it's important as we start to think about guidelines. Now, in anything, when we deal with patients, and how we implement guidelines is through shared decision making, and we have to involve patients and we have to recognize their preferences and values in terms of what they're willing to do in terms of controlling their hives, and they have to understand what these medications do, their side effects, and as we have more real world evidence with some of the newer agents. Of course, we have a lot of information with dupilumab because it's been around for other indications for a long time. But with remibrutinib, we'll have to have more long-term real-world evidence to show that it truly is working as the clinical trials indicate. But this is something we have to really discuss, and our recommendations for should be equally balanced between the patient's personal preferences and values and the physician's knowledge of the management of urticaria. So So what does it mean to implement the guidelines? Well, as I mentioned, we need more real-world data studies to show how these treatments work in the in patients beyond clinical trials. We need again, this comes in the form of publications, which are a great source for physicians, for medical professionals, but also disseminating these guidelines through international, national, regional, local meetings, through just talking to patients, clinicians talking to their patients who have hives about urticaria, the disease pathogenesis, and they should try to be more granular when they talk to patients. I find that my patients, if you can break things down and simplify it, they understand fairly complicated concepts, and it makes them more compliant, more adherent to treatment, and more engaged in their management. These UCARE, ACARE webinars are great. There's a large outreach. I see that we have 107 people on the call. This is a great way of implementing guidelines. Okay, and I applaud the organizers of these conferences. I think they need to be. These are great. They should be continued. And the problem in the United States, we don't have enough UCARE sites. We only have about 7 certified sites. So we're working to help create a greater network of UCARE centers in the United States that would help participate in this initiative that is a world initiative. So hopefully that will help in the future to disseminate guidelines. And then, of course, patient advocacy groups. So I should point out there are these groups now. We See You is an international group that has been developed. Kristen Willard was supposed to be giving one of the talks. She had a conflict, but she's certainly helping to run this along with there's a board of directors, and I think they're making good headway. So this helps with patient education. So when we think about all of these processes, there's many ways of implementing these guidelines. The options are much greater than what we had. It's getting more complex than just omalizumab and antihistamines and cyclosporin. We have now real understanding of pathogenesis of chronic spontaneous urticaria and inducible hives, and I think we're going to have more targeted therapies. I understand there's at least 31 drugs being developed now for chronic urticaria. So how are we going to deal with all these therapies? It's really essential that we have these channels for implementing updates and of guidelines so that people stay abreast as to what's going on. So with that, I'm going to conclude, but the future is bright for patients with chronic spontaneous urticaria and chronic inducible urticaria. Thank you for inviting me to participate in this conference.
Thank you, Jonathan, so much for shared expertise, and extremely interesting and exciting is the future for urticaria patients. Thank you for touching upon also the shared decision making, the behind creating the guidelines and developing that. A lot of research, a lot of work, a lot of literature, few heights, but at the end of the day, it's all aiming towards the improvement of urticaria patients' life and receiving the disease control. So with that, I would gladly open up the discussion field together with the patients, because I'm extremely excited to have today also with us Vildana, who is representing the patient side and has prepared a lot of questions when it comes to actually impact of the guidelines and how the guidelines may fulfill the current needs or missing points in the care of urticaria patients. So, Vildana, I will be very happy to give you the stage.
Thank you, Ais, very much, and it's a great pleasure to join you today. So I would like just to stress that I'm here on behalf of GAP, it's a global allergy and airways patient platform, to bring forward exactly as you said, the questions and perspectives of our patient communities and patient advocates and community leaders. And I really look forward to contributing to this important discussion. And I love it because it's very interactive, and this is also always very fruitful. So I will start with asking the questions that we collected and the one that we really need to know, and it's great to address to you. So I will be very general, so whoever finds it willing to answer, we'll be more than happy to hear. So the first question is, do the guidelines differ between countries or specialists? So I come from Eastern Europe, and it's always very, very interesting to hear the answers about similar questions.
So, Jonathan, if you would mind taking the question whether the guidelines are different throughout the countries or regions.
Well, yes, they shouldn't be if this is the idea of international guidelines. But the access to treatment's different, and the access to healthcare is different. So that there are obviously regions that we have access to everything in the United States, whereas some countries don't yet have a lot of these drugs approved, and they don't have access to as many to the healthcare. Maybe many times primary care doctors might be treating these conditions, and they don't have the knowledge as well. So there is that disparity, and that we need to try to address worldwide. And through these different channels, we can hopefully improve this process. But generally speaking, the guidelines should be the same. That's the purpose of international guidelines. Now, we do have the Joint Task Force guidelines, which are international because they also pull in all of the studies from all over the world. They're not just picking United States studies or North American studies, and so they should complement the existing international guidelines, not confound them. They should be consistent. It's just adding a different dimension, and it's updating it because, of course, when the international guidelines were generated and the last ones, and there's newer ones coming down the pike, they didn't have these other therapies. And so this will add the new dimension of these novel therapies that are emerging. But we hope that we can standardize things, and the biggest problem will be access to care, and that's the limitation that we have to address.
So before we move forward, I would just gladly pop in one follow-up question from the chatbot. So do we have the approximate timeline when the manuscript will be published with the new guidelines?
So
we're currently going through all the recommendations. We have our last call this week, actually, so we'll finish up the guidelines. We're already in the process of generating. We're working with McMaster's University in Canada. Derek Chu is the lead. As you know, Derek Chu is a very excellent methodologist and trained with Gordon Guyette, who is the father of great methodology. And so we anticipate that we should have something available in the first quarter of next year, of 2026, just getting everything, put together and reviewed. It goes through an extensive process because it's reviewed by patients. The whole process is, these recommendations aren't just physicians; they're people with HIVE.
Everyone.
They're people who are primary care doctors, emergency room doctors. We have a spectrum of people who are involved in this process, so it really is meant to provide that generalized input, and which is what you need, because everyone has a different perspective, and it's interesting how to participate in this process to see how it comes together. It is quite interesting, and so we're excited, and I think it will add to the existing literature and help us move forward as a group in how we can more effectively manage this condition.
Sure. Thank you. Vildana, please go ahead.
Yeah. Thank you, Professor Jonathan. That was really informative. And just to give you a short insight why the question was posed is, when you have information without the access, very often it leads to frustration. So it's always good to know that we have a different perspectives and different situations all over the world. So in different countries. So I'll go to the next question. So do guidelines recommend allergy testing for chronic urticaria? That's very common that we get from our patient community. So what would you say about that?
I would say absolutely no. The allergy skin testing, first of all, let me just ask our audience, why would you want to skin test somebody who's got welts all over their body? How would you interpret that? Number one, if someone has concomitant allergies, they come in and they say, I'm allergic to cats and I sneeze when I'm around them, or I have seasonal allergies, get a blood test, okay, to see if they're sensitized. But but those are people who have concomitant allergic rhinitis, which is totally different mechanistically from chronic urticaria. In our experience, most of our patients do not have allergies. They're not allergic to foods, so there's no need to do food testing. Again, when you start doing testing, you can have false positives, especially with foods. They're only about maybe 60% reliable. And like anything else, any test is only as good as its correlation with the individual's history. So routinely doing skin testing to aeroallergens and to foods is not recommended unless there's something in their history that would suggest otherwise. And that's why it's important to take a very detailed history and not just do things rote. We don't want to just empirically do things, and this is not recommended by our guidelines to do that. It's actually, we recommend collectively to do minimal types of tests and so forth. The question is, do we need to do more than just a CBC, a TSH, and a CRP? And now some people are saying, well, maybe we should do a total IgE and a TPO and a CU index, which is a marker for antibody against high affinity Ig receptors, and that's debatable right now, but it might help us in terms of decision making, especially now that we have other options. Do we go to omalizumab if patients have these biomarkers, or should we go to dupilumab, or should we go to remibrutinib or some other alternative therapy when these options exist? So this is the usefulness of these other additional diagnostic tests. But so I hope that is clear that we don't want to do allergy testing.
It is very clear, and you gave a great introduction to our next question, is how long should I stay on each treatment step before moving to the next one? So you mentioned medicine. So do guidelines describe that?
Yeah. And there will be some guidance on that. And I think that, generally speaking, some of these therapies work faster than others, but, with antihistamines, typically, when you updose to 4 times the recommended dose, we should see a response fairly quickly within 2 to 4 weeks. And if you're not really seeing improvement and patients still have high UAS scores and poor UCTs, then you either make them suffer longer or you try something next. And that's where you want to make a decision to go on to the next step. And do you want to introduce a biologic like omalizumab? And again, I personally am in favor of getting, now that we have alternative therapies, getting some of these biomarkers. But then the options would be dupilumab or remibrutinib or OMA, and then I think once you're on these drugs, again, we really should see some effect. But probably omalizumab, there is a delayed response in some patients. They don't work so quickly, and so you probably want to give it at least 4 months, to really say yay or nay. Some people would say longer, but I think that's sufficient. With Remi, you're going to see a faster onset of action, and so you would expect to see an improvement within 4 weeks. But you might give it longer as well. You're making a commitment. In the United States, we have to do prior authorization. It's a big deal to put people on these drugs, and they're expensive drugs. And so we want to make sure we give it a real good trial, about at least 3 months, to see if there's an effect. And I would say the same thing with dupilumab. Those are timelines, but there's no good. These are clinical recommendations. They're not evidence-based, so to speak. It's good clinical judgment.
And since we are already on the discussion about the medication, I would like to also throw in a question from the chat. So the new medication is always a buzz, always extremely exciting. And the people are willing to know about the experience. So I would probably rephrase the question, and I would ask you, could you already describe the patient profile that would be best suitable either for omalizumab, dupilumab, or remibrutinib based on the clinical history? What are shortly the main points? Which endotype would be suitable to any type of medication, or is there not known this type of thing yet?
Well, we do have some biomarkers that we know are elevated in antihistamine unresponsive. High D dimers, high CRPs, patients tend to be less responsive to antihistamines. But again, that's going to be trial and error. If they don't respond, the patients who respond better to omalizumab tend to have higher IgE levels. When they don't respond, they're usually very low, less than 40 or even less than 20, and they tend not to have autoantibodies. IgG autoantibodies. We don't have good testing for measuring IgE. They tend to have negative IgE autoantibodies, so to speak, but which is autoallergy. It's been described, but we just don't have clinical ways of measuring that so easily. That's a laboratory test, but we do have other ways of looking at autoimmunity, like TPO, thyroid peroxidase antibodies, and then CU index, which is a way of measuring receptors on basophils to see if they're upregulated or downregulated and so forth. And that correlates with autoantibodies. So I would say that if those patients have autoantibodies and have low total IgE, I would probably look at either Dupi or Remi. If they have normal IgE levels and no autoantibodies, definitely omalizumab. And so that's probably the simplistic way of looking at it right now. The recent data has been presented of the biomarkers, and they don't seem like Dupi works whether people have high or low IgE levels, as does remibrutinib. And so the biomarkers that have been reported for omalizumab don't seem to be directly relevant to these other agents. Now, that's what we know right now, and I think real-world experience will give us more data on this.
Thank you so much. Well, Dana, I will ask you to shoot your other, and I'm afraid almost the last question, because the time is not always in our favor.
Yeah, I'll try to combine several into one. We're very much excited about the guidelines, and we would like to see them as soon as possible. So I'll just ask about, since in GAP we really focus on mental integration as well. So I'm interested if guidelines address the emotional impact of chronic urticaria, as well as do they say anything about the role of diet, stress, and lifestyle changes in chronic hives?
Yeah, there will be some comments about diet, and there will be some. Of course, they won't be official. They won't. There will be a lot of verbiage in this area, and certainly in the context of quality of life, a lot of the impact of a lot of the factors, the variables in quality of life, deal with the burden and that you suggest, that you're mentioning, and so there will be some, input on that and so forth. But again, the evidence for diet and hives is very low, low certainty, low evidence. Low histamine diets, there's no evidence. So these are but there will be, but certainly there's a lot of data on quality of life and the impact that hives has, and those deal with emotional burden and deal with a lot of the physical and emotional components that you're referring to.
Thank you so much. And just a very, very quick yes, no answers or the time, if we know it or not. Karolina, maybe about the dupilumab approval, when it may be available also in the Europe, and what is the status with EMA?
So the status is it should be approved after the 15th of November. So any day now, but we have
So it might always be today.
Yeah, could be today, could be tomorrow. And for remibrutinib, we're expecting it for the first quartile next year here in Europe.
Okay, great. And just a very last question about the cyclosporin, which probably is also yes, no, or answer that is a little bit more complex. Can cyclosporin be taken cyclically? So it means in cycles. Can that be done? Jonathan, do you know about that?
I'm sorry, you were mentioning cyclosporin?
Cyclosporin, exactly. Yeah.
Again, there are no good studies showing these different clinical ways of using drugs, but I suspect that clinicians, they do things off-label, and if you get somebody who's done well, normally when we see patients with cyclosporin, they respond fairly quickly. We'll see a good response within 4 weeks, and typically, we can taper. I usually taper down and see if because you can. And there's no, of course, evidence for that. I don't just start and stop. I taper down, and if they're to get to the lowest dose possible to maintain their control, and if they're doing well, I'll usually stop it. And most times, if they're responsive, I can stop within 6 months. Now, if it reoccurs, yes, there's no reason why you can't restart that. Monitoring blood pressure, monitoring kidney function, and other potential side effects. So, will this be the same with biologics? Possibly, but the bigger problem is getting, prior authorizations to do this all the time. I mean, and because there's restrictions in how these drugs can be used, so that may make it more difficult. Can dosing intervals be extended? Can the dose be reduced? Well, we saw this with omalizumab, where doses were increased and frequency was increased in patients who had partial response, and there was, weak evidence that as a good treatment, but people were doing this nonetheless. And so I think the same can be the opposite. We can reduce frequency when people are doing well, and we can reduce dose and see how they're doing, but rather than just stopping and starting. Now, what's the evidence to support that? That's if there aren't double-blind placebo-controlled trials for that, but I think that's like anything else. That's real-world experience. That's the art of medicine.
Yeah, we have a few real-world projects which will be finished next year. One talking also on this cycle, so with cyclosporine, when you stop the dose when you have no more symptoms, and how long does it take to come back? And then if you start again, if it goes slightly quickly, then the symptoms are under control. And something similar also going for omalizumab. So we will have more data in the years to come.
I have no doubt about that, and I'm very excited to get all your insights into the latest research. And I do believe that Valdana has so many more questions left, and that we will definitely need a round 2 for this webinar when it comes to the guidelines. So we collect all of your questions, and Valdana collects all the questions further on, and this is why it's very important that you give us your feedback for us to know how we may improve, and stay in touch with us. We are always there for you. Especially, we encourage you to visit the We See You. If you are seeking a community empowerment or a way to become a voice in the patient advocacy, this might be a place for you and might be your chance. So please be sure to visit the website and subscribe to our newsletter, because we're definitely doing a version 2 of this webinar with follow-up questions and going a little bit more in depth. Or please be sure to stay connected with us through the social media platforms. We are always only just one message away from you, and we'll be sure to address all of your questions. So thank you so much all for your time, for your engagement, and I'm looking forward to see you next time. Have a lovely day, and until we see each other again.
Thank you. Bye.
Bye-bye.
Bye.
Bye.